The next chapter, we're going to talk about angina and agents, so cholesterol agents, in chapter 21. Objectives are going to describe how the myocardium receives its oxygen and nutrient supply, explain the pathophysiology of angina pectoris, identify positive lifestyle changes that may be implemented to manage symptoms of angina, categorize drugs used to treat angina based on their classification and mechanism of action, summarize the links among high blood cholesterol, low density lipoprotein levels, and cardiovascular disease, compare and contrast the different types of lipoproteins, describe how lipids are transported through the body, and give examples of how blood lipid levels can be controlled through non-pharmacological means. Categorize anti-hyperlipidemic drugs based on their classification and mechanism of action, identify representative drugs and explain their mechanisms of drug actions, primary actions, contraindications, precautions, interactions, and important adverse effects. So when we look at angina, and which we'll talk about, there's several different anginas. There's unstable, there's stable, but just talking about angina in general, this is caused by severe chest pain that is caused by the lack of sufficient oxygen flow to the heart muscle. So if that heart muscle is not getting that oxygen that it needs, then it's going to cause the chest pain, the angina. It also can be due to heart disease, to where you have the plaque buildup. It becomes hard to where that blood flow can't get through there. And eventually it will lead to a heart attack where the plaque will crack and the blood clot will block the artery itself, and then it's not getting no oxygen whatsoever to that area. So some signs that you may see are cold, can occur when it's exercising, when somebody's cold, they're worried, angry, are some of the triggers that can bring it on. Typically, usually angina is preceded by a physical exertion or emotional excitement. It'll diminish with rest in less than 15 minutes. The most common cause is going to be your atherosclerosis. And there's, so you're wanting to get continuous supply of O2 and nutrients to the myocardium, to that heart muscle, for it not to cause the angina. Remember that there's two main arteries, the right and left coronary. So if there's a moderate blockage or something going on, and this is going to cause your angina pectoris. If it is severely blocked, this is what's going to cause the MI to occur. Okay, so what occurs in angina pectoris, which kind of just went through. Most common cause are your atherosclerosis. Stable angina is predictable in its frequency, intensity, and duration. And there's no change in the past 2 months as well. Treatment, they can use beta blockers, calcium channel blockers, nitrates, which is your nitro, and potassium channel openers. Unstable, this is more frequent or severe and occurs during periods of rest. This does change in pattern. We're going to use aspirin or Plavix. And there is one more, a vasospastic. This is when the spasms of the coronary arteries due to a sudden narrowing in that artery. Pain periods of rest, so they're still going to have it while they're sitting, watching TV, laying in bed. No activity causes can be increase in blood pressure, increase in cholesterol, alcohol withdrawal, stress, exposure to cold, vasoconstrictors or stimulants. Classification of drugs can cause this as well. So when we talk about chest pain, I also want to talk about things that other conditions that may mimic chest pain, but there is no cardiac relation to that. So those would be your diabetes mellitus, your gastric reflux, and then your peptic ulcer disease. And then the ones that are cardiac related are going to be your coronary artery disease, MI, hypertension, and mitral stenosis. Okay, so positive lifestyle changes that the patient can exhibit are do, because taking medication, that is not a positive lifestyle change. A positive lifestyle change needs to be when they can eliminate something from their diet, from their lifestyle, that's going to help avoid angina occurring or high lipids. So limiting alcohol, eliminate foods high in cholesterol or saturated fats, keep blood cholesterol within normal limits or within normal range. Do not use tobacco, keep blood pressure within normal range, exercise regularly, keep blood glucose levels within normal range, and limit the salt intake and reduce stress levels. If these medications and other things don't work, people may have to have surgery. 2 different surgeries that they can do are percutaneous transluminal coronary angioplasty, which is your PTCA, where they'll go in and do it with stents. And then you have your coronary artery bypass graft, which is your CABG, where they'll go in, they take usually the saphenous vein out of your leg, and then they'll make a new route for that blood supply itself. Okay, so the first medications that we're going to talk about are your organic nitrates, nitroglycerin, isosorbide dendrite, and isosorbide monotrite. This is going to be, those last two medications are typically what people are on PO wise after for maintenance. Nitroglycerin itself is going to dilate those veins and decrease the venous return, which is going to decrease that cardiac oxygen demand. Prismental angina reduces the coronary artery spasm, increasing the oxygen supply. And this is another name for the vasospastic angina. So once again, the different types of angina, which we've kind of gone through. So just review these. Okay, therapeutic uses: treatment of acute angina attacks, prevention of chronic stable angina or variant angina, which is your prismental complications. Headache, which you can use aspirin, acetaminophen, or any other mild analgesic to help relieve. So this is the one thing you definitely want to forewarn your patients, because no matter if they get it under the tongue sublingually or they get it IV, you want them to know that they're going to probably experience a headache, and probably sometimes a headache like they've never had before. If somebody is on a nitro drip, then probably want to see if doctor will put them on around the clock acetaminophen, something to keep on board to help alleviate that headache. Orthostatic hypotension, so just make sure that if they start to feel dizzy or faint, that they sit down or lie down, and then just avoid changing position slowly. Reflex tachycardia, you need to monitor vital signs. If this occurs, they can administer a beta blocker, usually typically metoprolol. Tolerance. So providers, you want to start out at the lowest dose. This is more for if people have to wear nitro patches. They need a break. Your book says 10 to 12 hours of no medicine, so they need the patch needs to be taken off. So typically they take it off at night, or they'll withhold the nighttime dose to where they don't have that tolerance is not going to be built up. Contraindications: pregnancy risk category B for PO, and C for other formulations such as your nitro paste. Hypersensitivity, so just making sure that they're not allergic or have a sensitivity to the medication. Severe anemia, closed angle glaucoma, traumatic head injury. And both of those are more due to the vasodilation that's going to occur with that, knowing that there's pressure buildup already with closed angle glaucoma and a traumatic head injury. Precautions: antihypertensives, medications, hyperthyroidism, or kidney or liver dysfunction. Interactions: alcohol, antihypertensive medications, and your PDE5 inhibitors, which is your erectile dysfunction medications. Nursing considerations: sublingual tablet or sublingual spray. Usually rapid onset, short duration, used for acute attacks. They're going to take it at the first indication of chest pain. Don't wait till the pain is severe. Go ahead and have them take it. Take this medication prior to activity known to cause chest pain, such as climbing a flight of stairs. For the sublingual, just have them place it under the tongue and just leave it. Don't have them moving their tongue around because it may be displaced to where it could either be swallowed or placed in the buccal area. They need to be stored in the original bottle in a cool, dark place. So it comes already in a brown bottle. That's where they need to stay because they cannot be exposed to light. And then the spray that's translingual spray against the oral mucosa, and do not inhale it. So your sustained release oral capsules, this is a longer duration, short onset. It's for long-term prevention of anginal attacks. Do not crush or chew them. Take it on an empty stomach with at least 8 ounces of water. The transdermal, once again, is a long duration, needs to be on a hairless part of the skin. So typically we put it on the chest. It can be on the abdomen and thighs. Rotate the sides to prevent any skin irritation. Remove the patch. Wash with soap and water. Dry it thoroughly before applying your new patch. And make sure they wash their hands good. You as the nurse, make sure you use gloves when you are handling this. Okay. Topical ointment. Basically the same thing. You're going to apply it at a measure the specific dose, typically usually 1 inch. You do a 1/2 inch to 1 inch is what doctor usually uses. Apply to the hairless part of the body and have it with clear plastic wrap and tape it down to make sure if they're going to get in the shower, that it doesn't get wet. And then have them avoid touching the ointment with their hands. So treating anginal attack using sublingual tablets or translingual spray. You're going to take this every 5 minutes times 3 for the sublingual. Make sure they monitor their blood pressure, or if you're giving it in a hospital setting or long-term care, make sure you monitor their blood pressure, that it doesn't bottom out. And then that they can't chew it, crush it. They just need to place it under the tongue. Okay, going on to lipids. Triglycerides are your most common. They're the major storage of fat. Steroids are your cholesterol. The negative role that it's going to have is the atherosclerosis, if I could talk. Phospholipids are the essential to building cellular membranes. Okay, so your low density lipoproteins, this is your bad cholesterol. So you need to keep them lower. You don't want them high. Transport cholesterol from the liver to the peripheral tissues and organs. Your high density lipoproteins, this is your good cholesterol. This is what removes that cholesterol. It is transported to the liver, used to make bile, and then the lipids are going to be excreted through the feces. Your very low density lipoproteins, these are bad as well. This is a primary carrier of triglycerides. It's made in the liver and then it's converted to the bad cholesterol, your low density lipoproteins. Most of the triglycerides are transported to the adipose tissue for storage. So this is just what that fat builds up in our body. And then increases levels are associated with the risk of pancreatitis. Okay, once again, lifestyle changes that can occur: exercise regularly, maintain optimum weight, reduce dietary saturated fat to 7%, reduce cholesterol intake to less than 200 milligrams per day, increased intake of whole grains, vegetables, and fruits. Total dietary fiber is 10 to 25 grams a day, and reduce or eliminate tobacco use. Okay, your HMG-CoA reductase inhibitors, this is your statins. So torvastatin, simvastatin, and rosuvastatin. So your Lipitor, Zocor, and Crestor. The action is gonna be to decrease the synthesis of your low density lipoprotein and your very low density lipoprotein, increase the synthesis of your high density lipoprotein, promotion of vasodilation, and decrease in plaque site inflammation, thromboembolism, and the risk for atrial fibrillation. Therapeutic uses: primary hypercholesterolemia, prevention of coronary events, protection against MI and stroke for clients with diabetes mellitus, increase in levels of high-density lipoproteins, primary prevention in clients whose low-density lipoproteins is within the expected reference range. Okay, complications, hepatotoxicity. So looking at your liver functions, you want baseline. Then you want to have the physician check these at 12 weeks after starting the medication, and then every 6 months after that. You need to observe for the anorexia, vomiting, nausea, jaundice, and let the doctor know as soon as possible if you see these occur. Avoid drinking any alcohol due to it affecting the liver. And if your liver enzymes are not staying within the normal range, then the doctor may discontinue these. You're also looking at your AST as well as your ALT, aspartate transaminase is what your AST is. Myopathy, this is muscle aches and pains, tenderness. This can progress to inflammation of those muscles, myoitis, and then rhabdomyolysis, which is that rapidly wasting away at the muscle. So you're going to look at your CK, which is your creatinine kinase, and monitor that throughout therapy. If the patient starts having any of these symptoms of tenderness, pain, or aches, they need to notify the physician. Contraindications: pregnancy risk category X, liver disorders and breastfeeding, and then Asian descent. Precautions: liver disease, acute infection, electrolyte imbalance, severe metabolic disorders, kidney impairment, lower doses if that is the case, interactions, fibrates or dieta, erythromycin, ketoconazole, IV, HIV, protease inhibitors, amiodarone, cyclosporin, and grapefruit juice. Nursing considerations: they can take without food. It is better to take at bedtime because that is when the cholesterol is being made and processed. And then atorvastatin is preferred choice for clients with kidney impairment. Baseline labs are cholesterol, HDL, LDL, triglycerides, and then any liver and kidney function tests that needs to be done. Okay, so Zetia is the next one. This is your cholesterol absorption inhibitor. This is going to inhibit the absorption of cholesterol in the bile and from food. Therapeutic uses: diet modifications, can take this medication alone or as adjunct in combination with a statin to help lower your LDLs. Once again, complications: hepatitis, myopathy. Since I just went over that, I'm not going to repeat. It's the same signs and symptoms, the same things that you're going to be looking for. Contraindications: alone if it's pregnancy risk category C, active to moderate to severe liver disorders and breastfeeding, and precautions are mild liver disorders. Interactions: bile acid sequestrins, statins, fibrates, cyclosporin. They need to report any muscle aches and pains, and then follow a low-fat, low-cholesterol diet with exercise regime. Okay, the next one is your bile acid sequestrins, cholestyramine, which is questrin. Decrease your LDLs. Therapeutic uses: it can be used alone or as adjunct with an HMOG or CoA reductase inhibitor, so your statins, and with their dietary measures to lower cholesterol levels. Constipation is the only complication, so increasing fiber, exercise, increasing fluids. They need to take this with at least 8 ounces of water when taking this. Pregnancy, category C, is contraindicated, as well as bowel obstruction and pancreatitis due to the high triglyceride levels. Precautions, biliary disorders, or diabetes mellitus. So nursing considerations: take with meals, mix in 2 to 3 ounces of water. Do not take 1 hour after or 4 hours before medications, and use the scoop that came in with that medications. Do not let them, get another kind of scoop or a spoon. They need to use the spoon so they get the accurate dose. Nicotinic acid, or niacin. This is going to decrease in your LDLs and triglyceride levels. Therapeutic uses: the risk for pancreatitis and elevated triglycerides, lower elevated LDLs and triglycerides, and raise your HDL levels. Complications: GI distress. This is usually goes away. It's self-eliminating. They can take it with food. Facial flushing and feeling of warmth. You can take aspirin 30 minutes before each dose. You can have tingling at the hands and feet as well. Hyperglycemia, so monitor blood glucose a lot closer. Hepatotoxicity, once again, baseline liver function tests and monitoring for those signs and symptoms. Hyperuricemia, which is you need to monitor kidney functions, BUN, creatinine, eyes and nose. They need to intake at least 2 to 3 liters of water a day. And then if your uric acid rises, then they can do allopurinol to help that. It is a contraindicated pregnancy, risk category C. Liver disease or gout, because gout is what the uric acid produces. It produces the uric acid, is the gout. Precautions: diabetes mellitus, asymptomatic hyperuricemia, peptic ulcer. Nursing considerations: take with or without food. Then your fibrates, which is Lopid. It's going to help decrease the triglyceride levels, increase your HDLs. Therapeutic uses: reduction of plasma triglycerides, your very, very low lipoprotein density lipoproteins. Low density, sorry. Increase your levels of HDL. Once again, GI distress, it's usually self-eliminating. It's very mild. Gallstones can occur. So looking for that right upper quadrant pain, fat intolerance, or bloating. So if they go to McDonald's and eat a meal, they may end up having pain afterwards because of that fat intolerance. And then they need to notify their physician. Myopathy, once again, and your hepatotoxicity. Contraindications: pregnancy, risk category C. Liver disorders, severe kidney dysfunction, gallbladder disease. Interactions: warfarin, statins, and then they need to take medication 30 minutes prior to breakfast and dinner.